Hello, this is Jason Rowe. Today I'll be talking about electrocardiograms and some correlations with cardiac events. Electrocardiograms are often abbreviated ECGs, which I will use a couple of times. And if I can get my slides to go. Okay, sorry about that. So electrocardiography, it's a very non-invasive and readily available test. They're available everywhere in any kind of medical facility you go to. There's a good chance that you're going to have one of these machines. They're used to detect and help prevent cardiac issues, as well as monitor basic heart function of an individual. It's a great resource for heart health management. So here we see a diagram of how the electrocardiogram is set up generally. This is the machine itself. The machine is connected to the patient with a series of wires called leads. And these pads are attached to the body. Sorry about that. So the pads at the end of each lead can be placed on our body and they receive information. So how this works is the pads pick up electrical activity from the heart that happens as the heart beats. This information is sent from the pads to the ECG machine, and the machine records information as a graph. It gives a nice little printout showing the heart rate and rhythm. So here is a typical graph from an electrocardiogram. Each of the waves of the graph are assigned a letter. As you can see here, we've got P, Q, R, S, T, and U. Each wave represents an electrical event that is happening in the heart. So here we have a diagram of the graph with a diagram of the heart, so you can see how this works. The first wave on an ECG is called a P wave, which we have here. This indicates atrial depolarization, in which the atrial contraction happens. The P wave is the first wave on the ECG because the action potential of the heart is generated in the sinoatrial node, which is right here, and the little arrows going out. This is the action potential being sent through the nerve bundles to depolarize the atrial muscle. So using this, if they see an increased or decreased P wave, this can indicate problems with the potassium ion concentration in the body, and that's going to alter nerve activity. So a missing P wave indicates an atrial fibrillation, or cardiac arrhythmia, which the heart beats irregularly, preventing efficient ventricular diastole. Generally not fatal on its own, but obviously a sign that there is an issue with the heart. The next three waves, the Q, R, and S waves, they together they refer to as the QRS complex. This indicates ventricular depolarization and contraction. The Q and S waves are downward waves, while the R value is an upward wave, and it's the most prominently featured wave on an ECG. The QRS complex represents action potentials moving from the AV node through the bundle of nerve branches and the ventricular muscle tissue. So we go from here with the wave moving through the top part and then down into the ventricles next. So abnormalities of the QRS complex could indicate cardiac hypertrophy or myocardial infarction. The T wave at the end here indicates the ventricular repolarization, in which the ventricles relax following depolarization and contraction. The ST segment refers to the gap between the S and the T wave and represents the time from ventricular depolarization and repolarization. An elevated ST segment is a classic indicator for a myocardial infarction. And then following the T wave, there is another one called the U wave, which I'm not going to discuss in detail here. It's not always visible on an ECG because it's a very small wave comparison to others. It's not really used in this study that we'll be discussing. So all this wonderful information leads us to our focus today of a study involving a 12-lead electrocardiography, which is widely used for detection of cardiac disease. Electrocardiogram readings have been reported to be affected by aging and therefore can predict patient mortality. That means that age will show different types of heart patterns. So related to this, prediction of the risk of cause of death is an important part of epidemiology and allows for adjustments of medical treatments and modification of different risk factors, such as stopping smoking, statin therapy, blood pressure control for cardiovascular disease. So models based on cause of death have mostly been developed through the combination of weighing patients' characteristics like age, sex, and various comorbidities like we discussed, smoking, age, weight, things like that. But because the risk of all cause of death is strongly affected by the stage of each disease, applying simple categories of diseases to these cause of death, either the disease exists or it doesn't exist, makes it hard to adjust these risk factors to come up with a model of how at risk you are. Doing it that way ignores a wide range of individual differences in the disease status. And related, using electrocardiography, which as we mentioned earlier, is a non-invasive and readily available test. It's widely performed for detection and management of cardiac disease. Electrocardiograph enables the evaluation of the risk of cardiac disease in medical examinations. Many studies have shown that electrocardiogram parameters are affected by age. They're going to get different readouts of the heart based on your age. And through these complex equations, ECG parameters can produce a model of biological age. They can kind of predict mortality themselves, even in the absence of structural heart diseases. So by focusing purely on the person's age, a number of predictive models of all causes of death using ECG parameters have been reported and based on the concept that abnormal ECG changes represent serious comorbidities that increase the risk of all causes of death. So in this study we're looking at, they developed this predictive model for the cause of death using this 12-lead ECG set of parameters. They selected the parameters for the model from among hundreds of these automatically measured ECG parameters. In addition to putting at the beginning, the most important factor being the generalization of the study, they focused just on aging specifically. So they excluded patients with structural heart disease because they didn't want the effects of the heart disease to factor into just looking at like a generic basic outline of an average person's chance of death. So they use this database called the Shinken database. It's a single hospital-based database that was established in June of 2004. And it was a collection of data on all the new patients that visited this cardiovascular institute in Tokyo, Japan. So in the study, the database used the ECG results that had been collected since February of 2010. Their initial group of data that had like over 32,000 patients from that database. But after excluding patients with structural heart disease, patients that were under 20, patients that were over 90, and patients with a couple of other cardiac anomalies, they ended up with a total of just almost 13,000 patients data, 12,837 to be exact. That's how many patients were included in the study. And all this wonderful data was looked at using some very complicated math models using machine learning that they put together that would be better explained by somebody in a statistics class than by me. But using all this math, you see here they've got their the comparison of their first chart of ECG parameters for cardiovascular death versus all deaths. The gray numbers were the initial data that they had, and the red are the final numbers that they used once they had all their data sorted out, so to speak. So here we have their total results of everybody for the total of 12,837 people, and the breakdown by age and sex and different indications. So they weren't really surprised by their findings. The high predictive capabilities of this model were due to having a large number of ECG parameters and this application of machine learning. They feel that they proved that the ECG readings can be used as an additional predictor for mortality in patients. The parameters from the 12-lead electrocardiography can be applied to predict the cause of deaths of patients without structural heart disease. These parameters greatly contribute to the predictions, where concentrations in the QRS complex and ST segment indicated specific problems. They did want to make note that there are some limitations to their study that should definitely be discussed. All the participants in the study were Japanese patients because they got the data from the Shinken database from the hospital in Tokyo, who were Japanese patients who were visiting a specialized cardiovascular hospital, so that needs to be noted. So these results should be interpreted carefully. And also the parameters that they used, they were using a specific ECG machine. It was a General Electric machine. I'm assuming the hospital just had one type of machine in use there. So if they were to look at this data using a different hospital with a different machine, the approaches to how you look at the data or any algorithms used to measure the waves could be different based on the manufacturer versus the GE machines they used here. And then patients with, if they included patients with structural heart disease, the predictive models got more complex, and it started weighing heavily towards cause of death being cardiac disease because of the number of patients at the hospital with potential cardiac issues or cardiac disease. So they wanted to make note of that information with the study as well. So study definitely shows using the general predictors we use for different comorbidities, age, sex, weight, etc., and combine it with these ECG readings definitely is a worthwhile way to help determine types of potential death. And these machines, the technology is only going to get better and better, and the machines are going to be in more and more in place and used. So it's definitely a route that should be investigated. Thank you for taking the time to watch, and here are my references. Thank you.